Okay, welcome everybody. Welcome back to the Innovative Discovery Series. Be sure to sign in. Please RSVP so we can prepare for the next session. If you want CME, please do sign in. Next week we'll have Kalyan Pasupathy from the Mayo Clinic to talk about engineering Mayo Clinic's care delivery. That really sounds interesting. We also have the full series on the website. If you're, I think everybody here is part of the Delaware CTR. If you're not, shame on you, and please register and join the Delaware CTR. It's really a great thrill today to welcome Dr. J.Z. Sun from Thomas Jefferson University. So he's from our sister campus where many of us are on the faculty. He's from China originally, where he went to medical school and studied internal medicine. He did basic science research at Baylor University with the great Roberto Bolai, and then studied anesthesia at the University of Pittsburgh, coming to Thomas Jefferson and rising to be professor of anesthesiology. He has really interesting thoughts on cardiovascular disease and its relationship to surgery and revascularization. And he's going to lecture us today on cardiovascular complications. The Conundrum continues. Dr. Sun, thanks so much for coming.
Thank you very much. And thank you, Dr. Winthrop, for your very warm welcome introduction. And it's a great honor to be here and to give this presentations. And this is a book maybe someone had chance to read. And I'm a J.Z. Sun from Thomas Jefferson. So today the topic basically, and we're talking about prevent perioperative cardiovascular complication. And in this field, what's the issue and what's the problem and what we can do at this time. And this about 10 years ago, and we published a paper in American Heart Journal. It's the same topic, how to prevent perioperative myocardial injury. The conundrum continues. Unfortunately, and up to now, the problem still remains. Let's see the big picture. And in the world, the number one, the death and the killer, the still is ischemic heart disease. From this slide, you can see the number one is ischemic heart disease. Number two is cerebral vascular disease. In the United States, 2013, by statistics, heart disease is number one, and the killer, cancer is second. In the hospital, and the patients coming to hospital, most is because cardiovascular disease. You can see this disease, can see from this slide, according to hospital discharge and ICD-9 code, you can see cardiovascular reason to come to hospital is number one, the cause. How about surgery? In the surgical field, we see the surgery patients continuous increase. Why? One is because the people become older. Two is because the patients or people more and more rely on surgery to treat the disease. And according to the National Hospital Discharge Survey, inpatient procedure in this nation, 1996, 40 million. 8 years later, 2004, the 10% increase. Another few years, it's another 14% increase. Up to now, it's about 51 million per year. The patients come to hospital for surgery. So as we said, when the cardiovascular disease is number one killer in this country, two, more and more patients coming for surgery. What is the leading cause for surgical patients' death? According to a recent study, is cardiovascular cause. So today we'll talk about so-called perioperative major adverse cardiovascular events, or called MACE. As we said, by 2010, each year about 51 million people come in for inpatient surgery, including cardiovascular surgery and other non-cardiac surgery. This about 51 million people is about 16% of the US total population come to surgery. Among those 16% of the US population, 1/3 is above 65 years old. So 1/3, 30% is old patients. And as we know, surgery or perioperative stress is unique, extreme, and prolonged, including surgical trauma, bleeding, hypoxemia, anesthesia, prolonged complex procedure. This stress can last after surgery hours, days, even months. Complication, perioperative MACE or major adverse cardiovascular events are leading cause of postoperative complications. And although the cardiovascular complications is number one and the leading cause for surgical patient death, but so far the treatments or therapy to reduce or prevent cardiovascular complications surgically or medically, very few. This study published not long ago, 2012 in JAMA, is a big cohort study to show and to monitor, the surgical patients, how frequently you see cardiovascular complication. In particularly surgical, because patients under anesthesia, most often you cannot see, for example, chest pain or short breath, those symptoms, because most myocardial ischemia during the surgery or post-operative surgery is silent. The way to monitor or to detect myocardial injury is you check cardiac troponin. So this study monitored 1,500 the patients perioperatively monitor cardiac troponin. They found 11.6% of patients had significant or prognostic significant and cardiac troponin increase. So it's about 10% patients have a significant cardiac troponin increase. Those patients had a significant and mortality or morbidity. So this slides and showed a couple years ago by Anesthesia News, they showed myocardial injury within a month of surgery is third leading cause of death. Including the number one we said in the beginning of the slides is heart disease. Number two is cancer. Number three is cardiac reason caused surgical death. See this. So 10%, about 9% or 10% patients perioperatively had significant myocardial injury and detected by cardiac troponin increase. This is a patient's adult patients, 45 years older, and coming from major non-cardiac surgery. According just the slides, a vision study showed. So about 10% of patients, those adult patients, if you come in for major non-cardiac surgery, you had myocardial injury. Those 10% patients had cardiac troponin increase will be died within a month. Within a month will be died, according to this big vision study, 15,000. So in this scenario, in this condition, if 30 days after surgery were disease, it would be third leading cause for death in the United States. So that's why we say, and the MACE, or major adverse cardiovascular events, is a leading cause for surgical patients. So what do we have in our hands as a physician, particularly perioperative physician, to prevent or reduce perioperatively MI, or myocardial injury. So as a physician, and anesthesia doctor, and also cardiovascular physicians, often, patients before surgery, we call the perioperatively cardiovascular evaluations. According to the new or updated ACC/AHA guidelines, and we have a stepwise way to assess the patient's risk cardiovascularly. So basically, they evaluate those patients according to 3 category parameters. First parameter is clinical predictors. It includes major, intermediate, and minor risk. Then it's called in how serious the surgical procedures, how big surgery. So the high, intermediate, low surgical risk. Some, surgeries, minor surgery, that's considered low risk. The final parameter is function status, or we call it metabolic equivalence. In other words, is this patient how functional-wise, how far he can walk, can he take care of himself at home, and the function, the cardiovascular function. So according to this, and we give you a real clinical examples to see how this works. For example, this is a 65-year-old man. This kind of patient we daily can see in the operating room, coming for the laparotomy for coronary section due to a recurrent diverticulitis. Patient has history of hypertension, diabetics, angina, and exploratory laparotomy for bowel obstruction previously. So for this patient, if you come in for this major surgery, and often we ask cardiologists to see the patients do the evaluations. So according to the guidelines, if you see according clinical predictors, minor clinical predictors including those parameters and factors, that patient we just said is a 65 years old, he has hypertension, angina, diabetics, so is now meet with minor clinical predictors. It's more than this. How about major clinical predictors? Unstable coronary syndrome, decompensated CHA, significant arrhythmia, or severe valvular disease, and this patient does not meet here either, that 65 years old patient. But he meet here the criteria for intermediate clinical predictors that include angina he has diabetics, so he meet here. So for those intermediate clinical predictors, those patients, then you see the function and status. We said that patient have a function status looks good, moderate to excellent. But he's coming for high risk surgery for the coronary section, laparotomy, so the high surgical risk. So these patients, according to these guidelines, they need to go to non-invasive and cardiac testing. If they find something non-invasively, they further go down to consider coronary angiograph. So the patients, according to cardiologist presentation and recommendations, had a pre-op and cardiac stress test, which showed the patients further showed ischemic defects, non-invasive test. Further did cardiac catheterization, found 2 vessel CAD. So the patients had multiple vessel CAD coming for major non-cardiac surgery. So next question, what we can do for these patients? Right? We probably hear if as anesthesia doctor or cardiovascular doctor, or surgical doctor, or as a patient or patient care, you may have a similar question. For those patients, what we can do? So clinically, what we can do for those patients, just like above the patients? One is medical treatment. Let's see what we can do medically to treat those patients to prevent or reduce potentially cardiovascular complication. Unfortunately, not much. And according to recent study, the 2 big randomized clinical trials, POISE 1 and POISE 2. The POISE 1 and published 2008 in Lancet. POISE 2 just published about 2 years ago. So POISE went 8,000 patients randomized and to the treatment group, a placebo group. So those patients before surgery, 2 or 4 hours, start beta blocker metoprolol, continue for 30 days, and then they monitor these patients, follow up, see any cardiovascular events or death, and perioperatively. So this POISE went to try see how the beta blocker and is beneficial or not for the patient coming for surgery. POISE 2, they test aspirin and also clonidine. Basically, they gave aspirin or clonidine before the surgery, continued for 30 days, then see and how is perioperatively any cardiovascular complication or death. This study even bigger, more than 10,000 patients enrolled. Let's see POISE 1. This slide basically and showed how POISE 1 goes. So if you see this slides, the blue is the beta blocker, yellow is placebos. So you give beta blocker preoperatively, looks the beta blocker metoprolol, it is good cardiovascularly because if you CV death or cardiovascular related complication, MI and death is reduced from 6.9 down to 5.8, p-values 0.04. So beta blocker is protect heart and perioperatively. However, if you see this panel, the blue is beta blocker, yellow is placebo, about the death, fetal and mortality, total mortality, the beta blocker increased and surgical patients' mortality from 2.3 increased to 3.1, p-value significantly. So in other words, the beta blocker perioperatively, you give beta blocker, it protect heart, but increase the death. So which one you want? You want your heart? You want your survivor? So since this study published, the clinical and it's a big change, it's a switch. Before the POISE 1 study, and as my age, we remember that time, beta blocker before surgery, you give the patients if you have any indication, for example, high blood pressure, cardiovascular disease, or tachycardia, you give beta blocker, and become a routine, and also is become the clinical standard. And hospital administration ask you check your patient on beta blocker before the surgery. So since that, it totally changed. Now we seldom start beta blocker for the patients. This POISE 1. POISE 2, published New England Journal in 2014. Compare aspirin and placebo, follow up 30 days to see the events and perioperative major events, death. You can see aspirin compare placebo, you give aspirin preoperatively, and follow up 30 days, we not see any improvements concern any and adverse events. Instead, if you read this paper, this aspirin increase bleeding. And after this publication, we wrote the comments, which published in the JAMA. If you're interested in concerning the limitation and some potential, and flaw on the study, so that's what we published and in JAMA. This clonidine basically showed the same trend as aspirin. The clonidine, and compare the placebo, if you follow up 30 days, it also did not show any significant effects on the adverse events. Basically, it's a death. So that is medical treatments. If you looking back in the last few years, and very unfortunately, and I'm still thinking why those medication, beta blocker, aspirin, which already demonstrated and show it works in the patients, cardiovascular patients, why it not work in the surgical patients? It worked in non-surgical patients. Why it did not work in the surgical patients? That's my question. And probably still need more and study to be done on that field. But it's become difficult since those POISE, when the POISE 2 is a huge randomized clinical trial. Think about if you want overthrow that their conclusion, you have to design another and big clinical trial and to show that the difference is difficult at the current situations. So medical treatments seems not much encouraging news from the above study. How about the surgical or cardiovascular intervention? So here we see another way to see if you go to cardiovascular intervention rate, that can prevent and perioperatively and the surgical patients' cardiovascular complications. If you look in last 60 or 50 years history, in the entire interventional cardiology or cardiac surgery, we can see from this slide, 1950 is that start cardiac surgery, and in particularly 1953, the first and cardiac surgery performed on the heart-lung machine by John Gibbon in Thomas Jefferson University Hospital. That's 1953, first heart-lung machine successfully used by John Gibbon for cardiac surgery. 1960, they start first coronary bypass. Since then, the coronary bypass, the patient numbers increased significantly until they start changing. 1970, 1980, this 1970, they start first continuously balloon and coronary balloon and treatments, angioplasty. 1980, and start first coronary stents. Now, 2000s up to now, the first generation, second generation, third generation, maybe fourth generation, the drug-eluting stents already come to the market. So today, because international PCI, the cardiac surgery bypass number is coming down a little bit. But from this slide, what I try to show you is in treatment cardiovascular disease, interventional cardiology and cardiac surgery made big advance, and it coming it's a basic strategy or principle to treat cardiovascular disease. That is what we're thinking. If you have blocked or lanoed coronary arterioles, we got to revascularize that blocked or stenosis arteriole, so they get treatments to, and this is basically our treatment strategy. So there's a bypass, there's a stents, and it already showed, as I said, in the last 50, 60 years, those treatments work for patients have a significant and CAD in non-surgical patients. How about in the surgical patients? Is a bypass or PCI can reduce the patients and perioperative complications, surgical and heart cardiovascular reason. So this we started, we saw, everything, our strategy to revascularize patients. If you have significant CAD coming for major non-cardiac surgery, so if before you come to surgery, we revascularize your CAD, it's supposed to prevent or reduce your cardiac complications. Is that right? So the treatments to reduce the outcome related and CAD. So this we try to fish this chart. But what we got CARP. This CARP study published in 2004. The full name is Coronary Artery Revascularization Prophylaxis Trials. And this trial is not that big. They start 5,000 patients, but most excluded. Finally, I have 500 patients included in this study. So the 500 patients divided in two groups, 250 and 250. The half in the medical treatments group, another half in the revascularization group. The revascularization include PCI and CABG, so they mix the PCI and CABG in the same group without a detailed description how and what's the criteria those patients include in each of different groups. So then after those procedures, either PCI or bypass or receive the medical treatments, then after medium 45 days, you receive vascular surgery, the major surgery, vascular surgery. Then you see the perioperatively long-term and the outcomes. So if you see this, and revascularization was non-revascularization, the mortality and perioperative MI, both after 2.7 years follow-up, 22 versus 23, not significant. MI 12 versus 14%, also non-significant. So basically, according to CARP 12, their conclusion is, and if you have significant CAD coming for vascular surgery, you do a revascularization before vascular surgery, not no beneficial. This is a conclusion. But this study, although it's not that big study, only 500 patients included, and we thought it has limitation, have a big limitations. But although this rather and the small randomized trials they published in New England Journal of Medicine, they had huge impact on clinical guidelines. Today, when the patients come in for major non-cardiac surgery, even you have significant CAD, most often will not recommend you go to a serious and non-invasive cardiac testing, or you go to a coronary revascularization before your major non-cardiac surgery. Why? Because this study, because current guidelines, which was mainly based on this study. But this study, as I said, when the major limitation in the study sample size is pretty small. If you think about only 250 patients in each group, the final events, the deaths, each group is about 60, 70. Only few death events change in a different group will change the conclusion of the study. Actually, this study themselves, the CARP 12 themselves, they published a sub-study to compare, I just mentioned, they mixed the PCI and the bypass in the same group. So they probably also feel probably CABG compared to PCI, particularly for surgical patients, the outcome effects probably is different. So they did a post hoc analysis to see CABG compared to PCI in this sub-study to see any outcome difference. So if you see perioperative outcome, 30-day, death, and fatal MI. So if you receive the CABG before vascular surgery, the death, fatal and non-fatal MI, 6%. And the PCI groups, 22%. P-value is significant. So immediately postoperatively, bypass is better than PCI for prevent an MI. If you follow up, just follow up the later post-vascular surgical outcome, you follow up and 2.7 years. Again, you see the MI is 9 compared to 31%. 9 compared to 31%. So still show the difference. And as we said, those myocardial ischemia or MI, they're closely related to the death or mortality. And most patients had MI perioperatively. 10%, as we said, and they show will be died 30 days after surgery. So according to their study, this study also showed the bypass probably is better than PCI for surgical patients. And this their post hoc analysis show. And here we just want to mention another study, and this is a non-randomized study, and the case study published in 1997. And this study is a little bit bigger. They include totally 3,000 patients. 3,000 patients. If you come for minor surgery, these patients and either receive medical treatments or receive CABG did not show a significant impact on outcomes. Another about 2,000 patients that undergoing high-risk surgery. They further divide about 900 patients with CAD and had prior CABG, received CABG. Another 500 received medical treatments. So those patients coming for major surgery, before the major surgery, you got the medical treatments or you got the bypass. Then we follow up to see after major surgery to see the death and MI. So CAS study, they showed the bypass is better than medical treatments. If you see the death, 1.7 compared 3.3. MI, 0.8 compared 2.7. But the CAS study also have limitation. The big limitation, one, is not randomized study. Two, when they analyze the final outcomes, they did not factor in those perioperative complications related to the bypass. Related to bypass itself has complication of death. That the events did not factor in. So basically, and the ACC AHA, the guideline, recent 2014, their guideline is in one word: indication for further cardiac testing and treatment are the same as in a non-operative setting. So those are their recommendations. So the current situation is here. Based on the guidelines, ACC, AHA, the guidelines, many patients undergo preoperative testing for detection the CAD before non-cardiac surgery. Now we often hear, the anesthesia surgeon and also ask those patients to get cardiac clearance. What called cardiac clearance? That means if you have a history cardiovascular disease and symptoms, before surgery you got to see the cardiologist. So many patients undergoing those testing. However, there is uncertainty and much debate how to prepare major surgery for those patients who had positive results from the preoperative cardiac testing. That is, you receive medical treatments or you receive coronary revascularization. In other words, which treatment is best treatment for those patients have significant CAD coming for major non-cardiac surgery. So the current guideline, we believe, have the tool and the questions they did not answer. One, they said indication for further cardiac testing or treatment is the same as a non-cardiac setting, but in fact, surgical setting versus non-surgical setting is totally different. As we mentioned before, the surgery, particularly major non-cardiac surgery, is like what? Like big stress test for those patients. Because surgery involves trauma, bleeding, hypoxemia, anesthesia, all these prolonged surgical procedures can cause huge stress to the heart. So this itself is different in a non-surgical setting. And secondly, and so far, there's very few randomized clinical trials to support any treatment work or benefits for those patients who have significant CAD coming for non-surgical, non-cardiac surgery, including those treatments, medical treatments, and PCI or CABG. I just said we only have one randomized clinical trial so far available There's a CARP study which showed you receive revascularization or medical treatments, there's no difference. But they have a limitation in that study. So that's what we are looking back, those and the treatments. And how about the recent advance? Recent advance is coming from our colleague in cardiology and cardiac surgery field. And we can see those multiple vessel CAD patients, the treatment option, CABG versus PCI. And here we have Professor Dr. Winthrop, and he knows very well about those field studies. The syntax trial basically is a big randomized multiple nation study, spent about $50 million just for this clinical trial. 1,800 patients divided into two groups, and half, 900, go to the PCI, another half go to the CABG. Then follow up 1 year, 3 year, 5 year. This is final results. And 6 panels. If you see first panel up, and if you see mortality, CABG, blue lines, PCI, red lines, you compare follow 5 years, 60 months, not much difference. P-value is not significant. MI is significantly reduced by CABG compared to the PCI, and 3.8 compared to 9.7. Stroke, of course, the bypass will increase stroke. So 2.4 is PCI, 3.7 is the bypass. The stroke a little bit increased by the bypass. But here, if you see repeated revascularization, this panel, and the PCI compared to bypass is significantly more chance you get repeated revascularization either by PCI or CABG. So if you put all those events together, we call the MACE, major adverse cardiovascular events. The bypass compared to PCI, bypass is better than PCI. So syntax trial, the conclusion, the CABG should remain the standard care for patients, for those patients have a complex and lesions, coronary lesions, multivessel CAD. So this the syntax trial. When the syntax trial before the publication and 1 year before in European cardiac thoracic surgery and meetings, in that meeting they already announced, and for the multiple vessel CAD patients, the surgery is best for the most patients. This final syntax data and showed. And cardiac surgeon and David Taggart, and he said syntax finding are the most important results ever of any trial of stenting with CABG in the whole history of intervention. So this the syntax trial mainly is from the European groups. They lead these trials. Here from our United States, Dr. Winthrop and lead another trials and called a third study. And probably here most people and know these trials. And this is a huge observation study compared more than close to 200,000 patients, with 86,000 patients had CABG, another 100,000 patients had PCI. If you compare those multiple vessel CAD receive CABG or PCI, they follow up for about 3-4 years. They showed for those patients and bypass is better. Old patients and multiple vessel CAD. So this is a third study that also published in New England Journal of Medicine. And so syntax trial actually gave us a suggestion, indication, probably bypass is better than PCI for multiple vessel CAD. How about ourselves, the study? Is that outcome and matters? So this and ourselves, we did some study. As a clinician, we are really busy. So when I have time, and I try to do some clinical study. In recent years, and we focus on aspirin for the cardiac surgery patients. Those cardiac surgery mainly is bypass or valvular disease. We see how the aspirin before or after surgery, you give aspirin, that impact for the patient's immediate post-op or long-term outcomes. And the part of a study already published in Annexed Surgery. So those are recent study, and we completed, have not published yet. It's about 9,000 cardiac surgery patients from 3 institutions, from Thomas Jefferson, from Abington, from UC Davis Medical Centers. And those patients, and after exclusion, so 6,000 patients, they divided in 2 groups. One received the preoperative aspirin, one without preoperative aspirin. Then another 5,000 patients, one group received postoperative aspirin, one group did not receive postoperative aspirin. So we follow up. Immediately postoperatively, if you see 30-day mortality, received preoperative aspirin 3.67, did not receive 5.54%. The p-value is significant. So mortality by preoperative aspirin for those patients who receive bypass or valvular and surgery is significantly reduced. Macy also showed preoperative aspirin is better if did not receive preoperative aspirin, 10 compared 14%. And this is immediately postoperative. If you see long-term outcome, you see this just a static analysis with inverse probability V and method. So if you follow 4 years, you can see at end of 4-year average, received preop aspirin compared not received preop aspirin is 16 compared to versus 18%. And receive preop aspirin for long-term outcome, and still it showed better beneficial effects. Postoperatively, if you see postoperatively aspirin compared to no aspirin, the post-op aspirin also showed, if you follow up 4 years, it's 12% compared to 16%. And post-op aspirin you take and also show the benefits for long-term outcome for those patients either receive bypass or valvular procedures. So this study and what we try to show, if a patient take pre-op or post-op aspirin in this windows, those perioperative window you take aspirin, those treatments perioperatively can translate it to long-term and outcome benefits. And this study we try to show this. And those people involved and above study, including here and Dr. Winchop and Dr. Zhang, Zhugui Zhang, and the study we sent out to try to publish. So this is the last slides, and summarize my presentations. If you cannot remember above, and if you can remember this, is published enough. So at this time, for the prevent or reduce the perioperative cardiovascular complication, and this is current situations. Based on the guidelines, ACC, AHA guidelines, and the non-cardiac surgery patients, many patients undergo preoperatively testing for detection CAD before non-cardiac surgery. It's really costly. However, thus far, we're still uncertain how to prepare major surgery for the patients who has positive results from preoperative cardiac testing. Or what is best preoperative treatments? Medical treatments versus PCI versus CABG. In particularly for the patients with multiple vessel CAD, we don't know which treatment is better. Thus, recommendation and the decision are often made on the basis individual and institution experience or preference. And this probably you have those patients too. And we think syntax trial and shed new lights how to solve those fundamental questions in the perioperative medicines. Thank you. Yes.
Well, it was a fabulous talk, and it's a very important area, and you've really made it your own. You've become really one of the leading voices in the country about just what a huge problem this is. And I think a lot of people don't recognize, so it gets buried in everything else. But it's a tremendous problem. I just want to comment on a couple of studies. The problem with the CAS study, that's called immortal time bias, and you see that a lot, where the sickest patients are sort of pulled out. They already died. It influences the results. And you see that in a lot of observational studies. It's one of those things to really watch out for. Also, in the CARP study, well, that was a randomized trial. The comparison of PCI versus CABG was non-randomized. Now, that's particularly interesting. The numbers were small, but presumably the CABG patients were sicker, and yet they had better outcomes. And that's one to really think about, even though it's observational, and would seem to go along with the randomized trials of CABG versus PCI. And you're exactly right about that. Not only did the syntax trial show benefit of CABG, and we found that in the CERT, but the meta-analyses also generally show an advantage of CABG compared to PCI in preventing events. One of the things about the postoperative state is that you also have activated platelets. And that's very important in the pathophysiology of acute myocardial infarction, myocardial ischemia, injury, and infarction. So I think we actually stir the patients up. That leads to myocardial infarction. And on top of that, we have all the other stresses, hemodynamic instability, and so forth. So finally, this is really, you've made this, like I said, your area. And I think that many of us now need to back you in developing the funding for the randomized trials in this area. You're right, this area has been largely ignored, and we really need more randomized studies, and we're all behind you.
Correct. And thank you for your comments and suggestions. And it really is a huge and clinical problems, as Dr. Winchop indicated, for the patients coming for those surgery. And as we said, very few clinical evidence to support either of the treatments. Medical treatments, PCI, CABG, for those patients, very common. Daily, we saw those patients coming for surgery, for non-cardiac surgery. He had a significant CAD. What we can do? How we can help them? As a patient, as a physician, as a patient's caregiver, we don't know what is answer. So that's why I said most often depends the patient just himself, or depends which physician you go to see, or depends you go to Christiana, or you go to Jefferson, or you go to Penn. Each hospital probably different, each physician probably different for those treatments. No guidelines to support any of the treatments. So we do need more studies in this field. And now we try, and with Dr. Winchop's support and collaboration, and Dr. Zhang, we try to start some study in this field. And hopefully, sometimes we send a grant application, we feel very disappointed. They are not that understand or support for our proposal. So I will try to go further on the grant application and the studies. And good things, I believe, at this current conditions, and I believe we can try to get a randomized clinical trial in this field in China. And because there they have money. Two, they have patients. They have a lot of patients. And for example, and when I've collaborated in China, the #1 cardiac hospital, Fuwai Hospital, each year they do more than 20,000 cardiac surgery and case. Compare here, Cleveland, and the biggest cardiac hospital is much more than Cleveland. And however, in the United States, we have advantages of those data and already collected since 1980s. And those, if you do observation study, advantages clearly in this side. So we try to and also do observation study in this side. If we can get money to do a randomized clinical trial, I'd be love to, and in this field, but difficulty, particularly as clinicians. I only today I got a little bit time to come out and non-clinical day, and very few time to doing research. And yes.
Well, thank you for your talk. In disclosure, I'm a pediatric anesthesiologist, so I don't think about the adult problems as much. But I was just recalling with the POISE trial, when they showed the increase in mortality, if I'm not mistaken, that was in elderly patients and they had stroke. Am I correct in that?
Which trial?
The POISE trial.
POISE, the very first one you showed.
The perioperative ischemic trial where you had part 1, part 2, where they with beta blocker administration.
Oh, the POISE, yes.
Yeah, and they showed that.
Right. Yeah, and the deaths, basically, what if you go detail to analyze why the beta blocker causes more deaths than the final deaths, it's because beta blocker, if you give acutely before the surgery, they actually protect heart, but they drop blood pressure. Increased stroke. So I often talk with residents, you want to protect heart or you want to protect brain? It's difficulty, and you want to protect both, but sometimes you lose one. The balance.
Well, as a protective strategy, would you recommend, is there value in using near-infrared spectroscopy to see if you have adequate cerebral perfusion pressure when you're giving perioperative beta blockers? That's one question. Is there any value in that? Because they're using that in bypass. They're using it in bypass and ECMO cases now, because of the cerebral autoregulatory curve. Sometimes it's hard to predict what your optimal mean arterial pressure should be.
You're right. It's a difficulty, and I believe you should keep the balance. And actually, about POISE, and this is not controversial. And at least if you look at the literature, and the controversial, and including this start beta blocker acutely, is not chronic patient on the beta blocker. So current guidelines, if you chronically on beta blockers, they continue perioperatively, but they don't recommend you start acutely. This one limitation. 2, dosage. They think that dosage metabolo and is too big, and a lot of physicians. So in that field, the POISE and 1 trials is controversial. And about and the blood pressure control intraoperatively, pediatric, adult, and pediatric I'm not familiar. Adult is a lot of currently become a hot topic too. And the last anesthesia meeting in Chicago, they also talk about this, and intraoperatively looks their finding if you blood pressure tend to low, and that can increase cardiovascular events. So they said you should keep the blood pressure perfusion and a little bit on the high side, but they still need randomized trials on that. And beta blocker is endless stories, and need more study, I believe.
With the CARP trial, do you think that the results are difficult to interpret? In addition to what Bill mentioned, the fact that they excluded patients with left, if I recall, left ventricular ejection fractions less than 20%, and patients with significant left main disease were removed from that analysis. So you're left with healthier patients, which may give the impression that there weren't any differences. Do you think that had an impact on the analysis?
Yeah, you are absolutely right. And I mentioned a couple of limitations for CARP trials. When study sample size, 2, the mixed bypass and PCI. And 3, I did not mention, have no time, they exclude the number 1 indication for the bypass, that including aortic stenosis patients have a significant left ventricular ejection fraction low and heart failure, they excluded. And So those is actually is number one indication for patients coming for bypass. So they include those advantages and for the bypass. So
I actually think it was correct to exclude them, and I'll tell you why. Left main is not an equipoise, and everyone's going to revascularize people with left main disease. Everyone believes. The data are actually not so great. The data are 35 years old about left main disease, but it's not an equipoise, so we can't randomize them to revascularization or revascularization. Also, people with very low ejection fractions, they're going to die for different reasons. They're going to have heart failure, and they're not really a good test group for this. People, if you're sending someone to major non-cardiac surgery with an ejection fraction below 20%, this is a very high risk group, and the considerations about whether you should do surgery at all are quite significant. To me, that's a very different population entirely.
I agree. Probably that's why they excluded, but at least on the surface, it seems not fair for the bypass. Because that's advantage for the bypass. Those patients you exclude.
Well, at least left main are. I'm not sure below 20 there's an advantage, because so many of those patients are going to die of heart failure anyway. That it's going to be very difficult to save them with revascularization.
Yeah, I think that is one of the limitation for the randomized clinical trials, because they often select those inclusion criteria is very strict, and so their findings and cannot generalize to the general patient populations. So that's another way why we need those, like Dr. Winchop leaded this big observation study, assert study. So those from another side and can show if the treatments can generalize to the patients.
Exactly so.
Thank you.